Welcome everyone to today's training and information session around collaborative practice and roles. This session is intended for managers and practice leads in the area of eating, feeding, swallowing care provision. I just wanted to make a note that this presentation is being recorded in video format by Alberta Health Services. The recording may be used and disclosed by AHS for educational purposes and may be further broadcast by AHS for other presentations, publications, or promotions. This may include conversion to digital format, storing, and publication on AHS webcasting technology. So as we get started today, I just wanted to introduce myself and my co-chairs. We three are the co-chairs of the PEAS Roles and Implementation Working Group. Vanessa Steinke is a senior project manager with AHS, and she's the lead project manager for the PEAS project and also Superwoman. Tricia Miller is a manager of SLP, Audiology, and Children's Allied Health in the South Zone. And I am Melanie Mathieson-Dewar. I'm a manager at Alberta Children's Hospital in Calgary, overseeing allied health, rehab professions, and programs. So welcome again, and thanks so much for joining us today for this overview of the PEAS collaborative practice tools. Today's focus is to review what resources are available to you, to your teams and families with respect to roles in pediatric eating, feeding, and swallowing services. And so the objectives for today's session are threefold. To share the collaborative practice toolkit that's been created by this working group, to review the information and evidence around role clarity, which guided our development of role resources, including tools to assist teams to work through role clarity discussions, and to give a broad overview of collaborative goal setting and share some resources around this topic. We are, as a working group, are driven by the evidence-based fact that interprofessional collaborative teams are key to eating, feeding, swallowing safety and success. Quickly before we dive in, I'll just give a quick pitch for the other training opportunities that have occurred or are coming up into summer and fall. We've done an overview of new tools. We have had one session around the clinical practice guide. We've got today's collaborative practice and roles for managers and practice leads, and another session for frontline care providers tomorrow around the same topic. These presentations will be repeated in the fall, and all are being recorded for future viewing and posted on the PEAS website. And just to note that we're in the background actively working out details of what our innovation learning collaboratives might look like in light of the COVID pandemic situation. So stay tuned for more details about that. And now I'm going to pass it over to Vanessa.
Hi, so I'm just going to give you a really quick overview of the PEAS project. The PEAS project, Pediatric Eating and Swallowing, is a provincial quality improvement initiative with the purpose of developing a clinical pathway to standardize and improve care of children with pediatric feeding disorder as defined by Gaudet et al. For this phase of the project, our target population is for children in the ambulatory care setting, so we focused many of our resources on outpatient and community care, but they can very easily be applied or adapted to other care settings such as acute care as well. At the outset of this project, we hosted 2 World Cafes, and I think some of you may have been involved in that, or your staff. We hosted them in northern and southern Alberta back in 2018 to understand what was currently working and what was not working for the care of children with EFS difficulties. The results were very homogeneous, regardless of where people lived in the province, north or south, urban, rural. They interestingly showed that the most significant barrier to care was access to service and information, and then very closely followed by a lack of role clarity and communication. So these are just some of the examples from the World Cafe of issues that were concerning families as well as care providers around role clarity and communication. You can see there were concerns about understanding who provides what service, and that services occur in silos, goal setting, and a lack of multidisciplinary care. So this is why the PEAS project has a multidisciplinary provincial working group involving leaders, healthcare providers, and families to develop tools and support improved role clarity and interprofessional collaboration that's child and family centered. We're looking forward to sharing these new tools with you today that can be found on our new website, which can be found at peas.ahs.ca. So today we'll just be navigating you through the collaborative practice and role resources for healthcare providers, but we encourage you to watch our other presentations and just peruse the website as well. The other thing we just wanted to make mention of is that the website is mobile responsive and can be shared with families. So if you had the opportunity to attend our clinical practice guide session, Mona Danda shared some of her family's story as it relates to the clinical aspects of care. And in this presentation, she's going to share their journey as it relates to collaborative care, roles, and goal setting. In addition to being a mom of a child with an EFS disorder, Mona is also an IT project manager for AHS, whom we've had the privilege of working with to launch our new PEAS website. Over to you, Mona.
Thanks, Vanessa. So this is a picture of my daughter, Isha. She did and still has challenges with feeding herself and receiving the appropriate nutrition she needs. And so then to give you some background on history on her, she was not premature. She was born, she was in distress, and so we had an emergency C-section. She had congenital heart failure. She had respiratory issues. There was that unknown diagnosis of trisomy 21. And she was taken by Stork to the Royal Alexandra NICU, and we spent 4 weeks there where she was on a feeding tube, and she was also diagnosed with permanent hearing loss when we were there. And then next slide, please. So during the first year of Isha's life, we felt very supported. Although we didn't have specific assistance with feeding, we were seeing an SLP at the Edmonton Down Syndrome Society. We saw an SLP at the Connect Society. We received physiotherapy from home care, and then we had, all of our specialists and so on. We also had referrals to the Glen Rose. At the time, I declined that because I thought we were double dipping services. I saw that we already had 2 SLPs, one for hearing loss and one for Down syndrome, but they both focused on her speech. And so we didn't really have any assistance in feeding and swallowing. And I guess that was, I didn't know that that was the role of an SLP or an OT at that time. I also didn't know how complex, the basic skill of feeding yourself would be. And because Isha had a cognitive disability, I didn't realize that that was something that could be taught as well. And so, 8 years ago, I wished PEAS existed because I would look at this circle diagram that you have under the care coordination section in PEAS. And I would have likely understood the type of providers that I might have had involved in our life. I would have definitely sought some intervention at that time. I hope for new families that they can look at PEAS and learn about coordination of care and realize that regardless of where their child is in their journey, they'll have some support and who they can turn to. I eventually did learn all of this, but not until some years later. And I do believe in early intervention, so I regret some of the choices that we made. Now the next slide is her toddler years. Isha progressed. She was able to eat soft foods, and I started getting her to swallow foods. I would dose everything in yogurt and cut it up into small chunks. But that was even, not sustainable. And then also on top of that, you can see that she was really challenged in terms of getting food into her mouth on her own. So we did our best, but if I had PEAS at that time, I think things would have changed for us, not just in terms of teaching her how to feed, but in terms of ensuring I had the right emotional support. I did seek counseling at that time, and there's a self-care section in PEAS that provides a lot of options for families that are experiencing overwhelm. At the time, our SLP was costing us $180 out of pocket, and we're currently paying $135 for 45 minutes. And 60% of that comes out of pocket because of, the type of healthcare I have here at EHS. And so PEAS also explores different funding options that are available to families. And so I actually decided to seek intervention because at this time we completely isolated ourselves. We stopped taking her to birthday parties, and I had a terrible attitude. I didn't want to see other children thriving because I was jealous, and that was actually hurting her. Keeping her from those gatherings was, not beneficial for anyone. And so now when I look back, we've experienced collaborative care. There are a lot of things she still can't do in terms of feeding and other functions, but I'm not bothered like I was before. And I think the key difference is that I know that I've experienced collaborative care. I know that with the right assistance from the right type of team, that there are things I can do to help her succeed. And I think it was that feeling of not knowing what to do that really depressed me at that time. And so move forward, 3.5 years later, we received specialized services. And so we had a great team. We had an OT, behavioral consultant, SLP and SLPA, and we had a communication book that we shared amongst each other with quarterly reviews. It involved everyone on the team. Our clinicians kind of worked together, so they would share their notes with the other disciplines, so we didn't have to communicate our goals over and over again to them. We would do family goal setting, so that would keep us on track and we were all on the same page. And actually, I would say that feeding was the largest group effort because it involved everyone on the team. You know, we had to use the right language, work on her posture, work on jaw alignment, and, you know, we had our behavioral consultant that would help her to get excited for food and not frustrated because all she wanted to do was just drink yogurt and ice cream. Previously, we had 2 different SLPs, and that was also stressful from 2 different organizations because they would give us advice that would clash, and it was hard to decide what to do. The other great thing I thought about collaborative care was that they looked at our needs as a family and not just Isha as an individual. So everyone got involved, including my older child and my younger child, and so it was really amazing that we all had a role to play to help Isha, and they taught us how to provide care and give us some tools in our back pocket to give us confidence and help us to assist her. And so now, the next slide, please. We transitioned to school, and so now Isha's in a community school. She's repeating grade 1, and she has to decide whether she goes to recess or she eats food because she just doesn't have time to do both. And so that kind of results in some behavioral concerns, and she's fatigued by the end of the day. And I realized that it's complicated in terms of the school board has their own OT and PT and the teacher, and so we're not sure, you know, who's involved in helping her to feed because they all are very busy and you're working on helping an entire class. But we do know that throughout our journey, we've had a constantly evolving care team, and we've experienced different type of care. And I can strongly say that we've been the most successful as a family when we were part of a multidisciplinary team. I am so excited that teams are focusing on collaboration and that PEAS makes all the resources available to families. I'm really hoping that the information on PEAS is going to provide families to be more proactive rather than reactive, as I feel that we were the last 8 years. If I would have known, or families know that and understand right from the beginning that they're not alone on this journey, and they in fact could have an entire team of medical professionals at their side, it will reduce the feelings of overwhelm and ultimately provide better care for their children. Thank you so much.
Thank you, Mona, for sharing your journey and for your sharing your learning along the way. This is Julie Evans. I'm practice director for provincial speech language pathology. What a joy to get to know Isha a little bit through you, and it's just so powerful for us to hear about the differences our approaches make in the lives of children and families. So beyond our clinical influence, we really appreciate the opportunity to learn from you about that. And I think we are also gain strength from knowing that we're in this journey together with you as a family and with other families. So thank you for that. Aisha provides inspiration for our work, as do you. I'm going to pass the torch now to Carmen Lazarick, Practice Director for Provincial Occupational Therapy.
Thank you so much, Julie, and thank you, Mona. I definitely agree with what Julie's just said about the importance of your story. So next slide, please. So the child and family are at the center of what we do. In fact, putting patients first is an AHS priority. Child and Family First is an approach to care that focuses on the needs of the child and family, with healthcare providers working together to wrap around the child and family based on what their needs are. Regardless of one's role on the team, we definitely all have a role to play in supporting the child and family. The strengths and needs of the child and family are the foundation for how we then individualize our approach to service delivery. This client-centered approach requires that we ask the child and family to inform us, to inform our practice. We will talk later in this presentation about collaborative goal setting. The client-stated goals are what guides intervention. Everything we do connects back to what the child and family need from us within any given episode of care. This is what drives collaborative practice. What matters most to the child and family? Start with that. After all, they come first. And over to you, Julie.
Thanks. We provide excellent child and family-centered care through excellent professional practice. And I think sometimes we think that our individual clinical competencies and skills are the main foundation for professional practice. Indeed, they are essential. However, the literature is clear. Our interviews with clinicians and leaders have reinforced that quality person-centered care depends on the support of a strong system, team competence, and the individual clinician. Research demonstrates that team competence is essential for patient safety in healthcare, and really the individual competency alone won't get us there. How our system enables clinicians and teams to work effectively together is key to professional competence. And how teams communicate and work together is crucial to safety in all aspects of quality. We just heard about the difference communication and collaboration made in the life of Isha and her family. And I think that just reinforces the need for us to put a focus on that equal to the focus that we put on our individual clinical skills. Our individual competencies, including our collaborative practice competencies, are then integrated within the team competency and system supports to put professional practice into action. In preparing the resources that you'll learn about today, clinicians work together to better understand the unique and overlapping contributions among and across team members and disciplines. They were brave in challenging their own assumptions and those of others. Regulatory colleges, AHS, interprofessional, regulatory affairs, physicians, and multiple disciplines came together to create a robust set of tools that we believe will help you put professional practice in action to address what matters to children and their families. Thank you.
Thanks so much, Julie and Carmen, for that uplifting overview of professional practice in action. And thank you, Mona, for generously sharing yours and Isha's, your family's story. That sets the context so beautifully for us to be able to share the toolkit that we've built. We, in our work along the way, our working group was so fortunate to have been able to partner with COACT to harness the power of the work completed through this Alberta Health Services initiative over the past few years. The COACT Collaborative Care Design provides a framework and approach to implementing and sustaining collaborative care across the care continuum. And the guiding principles and pillars underpinning all COACT collaborative care elements include patients first, which we heard about from Julie and Carmen, high-performing teams, so enabling our teams for success, and quality culture, better value and better experience for our patients and families and for ourselves as practitioners. Having the advantage of adopting and adapting COACT's carefully created materials has been a huge boon to the PEAS project and allows for continuity and consistency across care contexts and areas of practice. Now, this graphic really illustrates the goals of the PEAS project with respect to building strong collaborative care teams and enhancing coordination of care and communication within the eating, feeding, and swallowing areas of practice. The feedback from the PEAS World Cafes indicated a disjointed or siloed current state, with teams separated by their discipline, their geographical area, or even by clinical program within the same site. So our goal is to provide teams with information and tools to help build care teams that are centered around the child and family and operating under a shared goal of best patient care, what matters to the patient and family, with fluid communication between all members of the team to promote interprofessional care, bringing together the unique perspectives of varied disciplines, regardless of whether people work in co-located teams or are geographically spread out. As we mentioned, we had the benefit of working together with COAC to develop collaborative care elements specifically for PEs, and they've now become part of the PEs Roles Handbook. So the 4 resource bundles included in our handbook are listed on this slide and are designed to support the operationalization of the principles of collaborative care. They are interdependent and they're applicable across the care continuum. We'll get into them a little bit more here. Instead of digging into each element individually and deeply during this presentation, in the interest of time, I'm going to show you where they're located on the PES website and would encourage you to take the time to review each of the elements yourselves. So in the For Providers section of the website, you'll see collaborative practice listed along the left list of contents. And simply click on the collaborative practice area and then read more under the collaborative care primers and resources section. The 4 elements of team charter, collaborative care team, assignment of care, and collaborative care leadership are accessible here as printable PDF documents. And we'd like to share a bit more specifically about developing a team charter, as we've found this to be a really valuable and edifying process for any team to undertake. Across Alberta Health Services, teams have really found that developing a team charter facilitates ownership of collaborative working relationships in the care environment. It enables the team to function in an empowered manner and provides a link between the team's goals and Alberta Health Services' overarching mission, vision, values, and goals. A team charter is a collaboratively developed description of the team members' responsibilities, accountabilities, and working relationships in the care environment. It defines the purpose of the team values, operating rules, and accountabilities. It provides the scope and approach to collaboration, outlines expectations, behaviors, commitments. It also provides an agreed upon process to resolve interprofessional conflict. Creation of a team charter really needs to be initiated and driven by you as operational and practice leads. It's a living document that should be revisited on a regular basis and when new team members are oriented to the practice setting. And the PES website will give you access to a team charter primer or info sheet, as well as a development guide and some templates, and examples of charters developed by existing pediatric eating and swallowing teams, such as the one you see here. So this one is an example of a charter developed by one of our eating, feeding, swallowing teams here in the area that I oversee at Alberta Children's Hospital. And I have to say that working through this process with a number of our teams has been gratifying. It's been productive. It's been challenging. Challenging one's own assumptions is sometimes hard work. It's provided the opportunity for a shared reference point, though, for our teams during any role-related discussions that come up or any team functioning discussions that come up. On the website, additional collaborative practice primers and resources can be found just below the team charter, and they include collaborative care team, assignment of care, and collaborative care leadership elements. And so each of the materials are brief. They're 2 pages. They include practical concepts, suggestions, and steps to implement and enhance collaborative practice in your own setting. We would encourage you to review them with an eye to how those key principles of collaborative practice may be put in place in your context to support practice, process, and quality care. And as we heard from Mona, the importance of that collaborative care was highlighted in the experience of that positivity in Isha's care, for sure. So how can you help as leaders? Well, I'll take a moment to highlight, as I mentioned earlier, that with respect to a team charter, it's essential that operational and clinical leaders are involved in initiating and propelling this work around role clarity. I'd like to mention specifically that the elements of collaborative care, leadership, and assignment of care really need endorsement, structure, leadership from operational and clinical leads, both. Sorting out how a team can best work through the questions and process of capitalizing on these evidence-informed elements of collaborative care will be unique for each team, obviously, and it really requires participation from all levels and members of the team. I'm going to turn it over to Tricia now.
Okay, thank you, Melanie. Going back to the original purpose of this provincial project, the lack of healthcare provider role clarity was one of the top concerns presented by families we serve, and that came out of the World Cafe meetings held in fall of 2018. The CADITH evidence review in 2017 provides clear direction that a team approach is required to best support safe feeding and swallowing assessment and care coordination, as dysphagia is considered a complex health issue. And we will cover your role as operations or professional practice leaders in use of these roles tools in this section of the presentation. The PEAS Roles and Implementation Working Group initially tackled review of the role resource supports for healthcare providers. Once the role resources were completed for healthcare providers, the resources were then adapted for families to utilize so that it would support the family journey related to their child's eating, feeding, and swallowing care. So your department, unit, or eating, feeding, swallowing team, you as a lead can use these resources to have conversations with your teams about services to infants, children, youth, and families. For healthcare providers, you will find the AHS developed PEAS roles, descriptors, and tasks within full scope on this new website under collaborative practice. And when you drill down more, you'll see the tools are intended to be used together as a package where you'll find specifics related to role descriptors, such as the scope of disciplines and overview of roles. In addition, the tasks for each discipline are a comprehensive list for an individual that happens to be working at full scope of practice. So you'll want to keep in mind that not every individual representing a particular discipline will be ready to work at full scope, but we wanted to make sure and ensure that each health discipline college or regulatory body confirmed each discipline's maximum scope. And as PEAS is an area, as is advanced area of practice, we acknowledge that individual healthcare providers may seek additional training and mentoring in order to work at full scope. These tools are used by practice leads or operational leads, and the task chart can be adapted for your specific team. So you'll just want to navigate and take a look at those tools. Together with families, clinicians, the Alberta Health Services Health Profession Strategy and Practice, AHS COACT, and professional colleges, the PEAS project has developed PEAS role descriptors and tasks within full scope for healthcare providers, just so that we could provide EFS clinicians with an adaptable tool to use as a way of highlighting, communicating, clarifying overlaps and gaps within a team. Also, promote interprofessional care by bringing together the unique perspectives of the various disciplines, whether we're in the same building or in different pockets of the province. Focus care team providers on their collective team competence. That was highlighted by Julie and Carmen earlier, and also provide a tool to identify and cover gaps in service. For example, the referrals or consults with other care teams, training, recruitment. And then as part of the roles, descriptors, and tasks within full scope, we have developed a diagram that addresses roles as shown on the left of the screen. This outlines the multiple and different care providers. As you can see, the dietitian, OT, SLP, psychologist, physician, nurse practitioner, nurse lactation consultant, and then a catchment for other disciplines that might be involved. It talks about different training and skills and the central role, again, highlighting that family is in the central role of the interdisciplinary care. And you'll notice the roles team decided to work with the graphic design, well, Vanessa worked with graphic design to look at how to blur those colors, just so that we can visually see too, or visually represent that there is that blurring between disciplines and roles as depicted in the diagram. When we look at the triangle, we have clarified that individual scope of practice is determined by ministerial regulation, professional regulation, employer policy, as well as individual competence. These tools can be used by you as practice leads or operational leads in your team meetings to support understanding of the importance of interprofessional collaborative care and to have meaningful conversations about the care we provide to infants, children, youth, families as a team. So Melanie and I just had a couple examples of our experience having these types of meetings. The meetings we held were a while ago now at Medicine Hat Regional Hospital. We found that it was important to the staff and managers that we had better clarity on roles based on past confusion. We looked at the sustainability of the service when providers moved from unit to unit or were taking on different positions. Every time we review a team's functioning on a unit or site, we often look at roles first. This then allows for respect of the various roles. And the work can be complicated and touchy, but it depends on each team's composition. We needed to review our scope of practice and then look at overlaps to determine what we were comfortable doing as a team, and we learned a lot together. There were aspects of service we discovered to better serve the family, like using education services. The wayfinding was improved, and we all had a better understanding of where to transition a child and family, such as acute care, community service, outpatient public health. And we wanted to discover who is the most appropriate person to do the task on a particular team for the safety of the infant, child, or youth. Each team documented their decisions on a chart for each discipline documented their decisions on the chart for transparency and clarity. And it built our understanding of when to involve another discipline pending the roles decision. After reaching consensus on discipline functions at Medicine Hat Regional, team members and managers expressed greater satisfaction with the delivery of service to infants, kids, and families.
And from our own personal experience here at Alberta Children's Hospital, an opportunity was identified to ensure that a full interdisciplinary feeding team is consistently available to infants and families in the neonatal intensive care unit, and to enhance coordination of care around eating, feeding, and swallowing. So we identified we weren't doing a great job of always having a full team there. We worked to ensure that there was FTE available from each of the disciplines identified as key players in feeding, and that included nursing, neonatology, dietetics, lactation consultancy, occupational therapy, speech pathology, social work, not to mention a focus on highlighting the parents as expert team members. Weekly feeding rounds were initiated about 6 or 7 months ago, and it's allowed real life experience to guide role clarity and collaboration between team members. Feeding plans are being made and are agreed upon by the family. Feeding plans are being made with the family. So again, this collaborative goal setting piece. They're agreed upon by the family and the interdisciplinary team after discussion and input. And so now at this point, feedback from the team is that the service has become much better coordinated. Care is shared and more efficient. The level of service availability has improved significantly on the unit for families. And in some cases, the length of stay is even shorter, which is a great outcome. From the nurse practitioner who spearheaded this work and continues to provide leadership to the team, she sent us a quote. She says, this work has brought the team to a point where we are cohesive. It's amazing and so important for our babes and families. Thanks.
Thanks for sharing, Melanie. So in addition to the roles, descriptors, and tasks within full scope, we have worked with the AHS Interprofessional Regulatory Affairs to create a frequently asked questions document that can be found when you look at this page on the slide, additional resources, and you click under the collaborative section, collaborative practice section. In Alberta, all healthcare professionals are required to follow provincial healthcare laws, legislation and regulation, professional college standards, employer governance, unless self-employed, and self-regulation when they provide healthcare services to patients and clients. These requirements are primarily in place to ensure Albertans receive quality, safe healthcare services. Healthcare practitioners from different disciplines may have similarities in their education and training. Despite these parallels, the role of each profession remains distinct as defined by professional practice statements, regulatory college standards of practice, and the competencies that are unique to each discipline. So the first bullet regarding restricted activities, the Government Organizational Act Schedule 7.1 contains a master list of healthcare activities that are restricted. These activities are restricted because they're considered to be risky and require specific education, training, and competence. Secondly, the term diagnose is not a restricted activity. Some professions have it within their scope of practice with their practice statements, college standards, and competency profiles to diagnose, and others do not. The dictionary defines diagnosis as to recognize and name the exact character of a disease or a problem by examination. The Health Professions Act is a framework document that provides common provisions that apply to all regulatory colleges and schedules that apply to specific professional colleges. All the regulated healthcare professionals have profession-specific regulations that provide governance. These regulations provide direction for what restricted activities the profession is authorized to perform and under which circumstances they can be performed. And then the two last bits here with collaborative competence. What does it mean working with an interprofessional collaborative team? Is when working in that collaborative environment where different regulated professionals care for the same patient or client, each regulated member works under their own legislative, regulatory, and college standards and remains individually accountable for the care they provide. And in terms of the role of AHS in directing how professions practice, AHS is accountable to uphold the Canadian provincial legislation, regulation, and accreditation standards. AHS develops process, resources, and tools that support regulated professionals, all healthcare staff, to practice safely and provide quality care. The AHS strategies, values, and competency statements help to describe expectations for staff working at AHS. AHS has the authority to decide on the role of a regulated professional in their position, but may not insist that a professional perform authorized restricted activities that are outside of their professional scope. And again, that's found in the Government Organizational Act. So with the screen in front of us, just want to point out the additional resources page. And when you take a look at the tools available, you can again explore at your own leisure to see the various sessions that you can click on and again round out that the roles and collaborative care approach with teams. Then moving into the next part of the website, we have resources for family members who are an important and that imperative member of the care team. They have an integral role as indicated in the literature, the research, in COAC principles, and in health change methodology as endorsed by AHS. There's also information about self-care that was mentioned earlier by Mona, and involving people in their community, such as the schools, friends, other family members, such as siblings, as well as information about finding a support network, including links to peer support networks for families whose children have an eating, feeding, swallowing disorder. Under the family section, we also have information for families about their care team and various roles that each provider may have. So this circle diagram that we saw earlier and highlighted by Mona is similar to the one for healthcare providers, but written specifically for families. Finally, in the care coordination section, there is also expandable questions for families to explore. So when it's expanded, if you click on what is my role as a patient or family member, how can we prepare to go home, with whom and when will follow-up occur, and another example is how do I talk to our healthcare team about our goals. So I think that's the end of the 6th section, and I'll pass it back to Carmen.
Thank you so much, Tricia. Okay, so now we're going to move in to talk a little bit more of a focused conversation around collaborative goal setting. And this has just been an awesome presentation so far. There's so many resources that are being made available for patients, families, managers, practice leaders, everyone. So now we're going to be talking about collaborative goal setting. We are thinking that, I think that everyone probably here on this call today, the presentation today, is probably thinking to some extent, we already do this, right? We already know this. So I'm going to try to take a bit of a more focused conversation to think about what is the evidence for collaborative goal setting and how do we make sure that we're actually doing it in an evidence-based way in our practice. So clinicians and teams intentionally engage clients and families in a shared decision-making process, resulting in functional client-centered goals. That's really what we're talking about here. And something to think about is that the client is really the expert when it comes to their values, their preferences and motivations. They are also the experts on how the health condition impacts their daily life and their family life. Healthcare providers are the experts on the health conditions and on the rehabilitation process. And why collaborative goal setting? So collaborative goal setting improves client outcomes. When clients and families are actively involved in making decisions about their goals, their engagement, satisfaction, and their motivation will improve. In practice, this translates to improved clinical outcomes, greater client commitment in rehabilitation, improved self-management, and we see things like fewer no-shows, cancellations, and fewer readmissions to rehabilitation after discharge. And on top of all that, it's also been and still is an organizational priority. The patient-first strategy and the patient-centered care approach are expectations in what we do in AHS. Collaborative goal setting is just really an explicit way to ensure that we are asking children and families what matters to you and collaborating with them in order to deliver our services. So this sounds reasonable and evidence-based. And then, so how do we do this? What teams already apply in terms of collaborative goal setting in practice, and then looking at how we can leverage leading practices that are already in existence out there. Many teams do set goals as part of their process, but may not be doing so in a way that is truly collaborative and patient-centered or in a comprehensive manner. Applying collaborative goal setting in practice is something somewhat new for some providers. We have not yet achieved complete consistency across Alberta Health Services. So let's spend another couple of minutes thinking about goals and some of the processes and supports that we can start to apply in our practice today. Goals. Goals should be recognizable to the child and family. They should be able to say, yes, that is what is important to me right now. They should feel that they own their goals. So it's not my goal as an OT, for example, that the child would be able to maintain trunk control or to be able to eat yogurt with a spoon, for example. Instead, it might be that the child and family goal is to be able to eat breakfast together as a family, and then there's going to be parts of that that each particular discipline will take action on in order to help the client and family work towards that goal. Goals are also not pre-configured. We don't know what the child's goals are just based on their health condition or even the presenting symptoms and functional issues. We don't know what the goals are until we engage in a shared decision-making process to establish what matters most right now. So we've covered the why behind collaborative goal setting, and now this slide will give us an overview of how this is done a little bit further. And how do we know if we are applying that evidence-based approach in goal setting? So one thing I have found really helpful is to think about this in terms of the 4 principles of collaborative goal setting. Collaborative goal setting involves shared decision-making. The goals are client-centered and client-stated. The goals drive intervention, and the goals are documented. It is through a shared decision-making process that we engage the child and family in establishing their goals, and that the goals that we end up landing on are indeed client-centered, can drive intervention, and can be clearly documented. And my final slide will focus on this clinical documentation of goals. While Connect Care is not the focus of today's presentation, it is important to note that we have built multidisciplinary tools in Connect Care to support collaborative goal setting in practice and to allow for documentation of goals and treatment plans. Currently in Connect Care, providers have access to an inpatient collaborative goals and treatment plan flow sheet where they can document the client-stated goals and the tasks associated with working towards each goal. And in the ambulatory environment, providers can use the treatment planning activity for easy documentation of goals and tasks. In both cases, there is an ability to document the progression of tasks. Until all programs and services have transitioned to Connect Care, we wanted to make sure that there are going to be some other tools and supports for practice in current documentation systems. A great example of this that has been adapted for use across pediatric eating and swallowing services and programs is the goal wheel. The center of the goal wheel is the client-centered goal statement, and the shared decision-making process is used to identify the actions or tasks that will enable progress towards that goal or those goals. So we heard from Mona earlier, and a wonderful story, and she did speak to some of the goals that she and her family had. We heard about the importance of that coordinated group effort and that in our approach to care, and that everyone on the team needs to know what those goals are so that the family members are not expected to be repeating that information over and over again. So I've taken a little bit of liberty in trying to give an example on this slide of a completed or a partially completed goal wheel and what this might look like. So in the center, we have something that perhaps Mona might have stated in one of her initial appointments, and that would be that she would hope that her daughter and her family would be able to participate in mealtime and including attending birthday parties. Some of the actions and tasks that might be documented with Mona and her family and with the whole team would be things like increasing motivation towards eating and social participation in meals, self-management strategies for family participation in reading or other communication activities, improve wiggle jaw and postural control and applying adaptive strategies for eating, and postural control and adaptive strategies for eating there as well. So that's an example of what a completed goal wheel might look like. It could have a lot more information on it, or it could be short and sweet. It really depends on the clinic, the approach, and really what the client is wanting. So I'll stop there and pass it back to you, Tricia.
Okay, thank you, Carmen. So quickly, just wanted to let you know you can contact PEAS by email using the PEAS contact form. For example, you can feel free to suggest any additional tools or handouts that you would like to be reviewed by PEAS leadership. Tools that are approved will be posted on the website. Please also consider subscribing to upcoming news and events through this website and subscribing to our community of practice. So just as chairs of the PEAS Collaborative Practice and Roles Working Group, Melanie, Vanessa, and I would like to reiterate our gratitude to the working group members we highlighted as well. The PEAS Steering Committee has provided us with great leadership and guidance in our journey, and we're thankful for their steadfast clarity in the purpose of this work. Thanks also to the PEAS leadership team, and above all, the family advisors and family members, Mona today, who have supported the purpose and vision of this work, which has become our North Star. Okay.
Thanks, Carmen, Vanessa, Tricia, Melanie, Mona. The website looks and is really fabulous. Want to just say thank you to our working group members again, and those of you on the line who supported their participation. The quality and depth of resources created has been just outstanding, so thank you. And before we move into answering your questions, we just would like to take a moment to remember our friend and colleague, Wendy Johansson, who was part of the Roles and Implementation Working Group. Wendy was a highly skilled and compassionate clinician who made a real difference in the lives of so many infants, children, and their families. Across the health system, we relied on her. I relied on her for her clinical expertise and her passionate leadership in the area of pediatric eating and swallowing. Wendy was a force within PEAS, touching on all aspects of service improvement. She had a clear vision of our ability to create coordinated, truly excellent services for children and families. Wendy Johansson passed away on July 21st, 2020, but her legacy lives on. Through our work to improve services for children and families, we will continue to honor her. So let's take just a moment now to remember Wendy. Thank you to Wendy, and our heartfelt condolences to all of you who knew her and loved her. Trish, do you want to take a minute now to answer any questions?
Thank you, Julie. Yeah, we just wanted to ensure that you're aware of the survey that can be utilized. So you'll see the availability of a survey. Sorry, that will be shared with you, link, and then just opening it up for any comments or questions.
This is the league from the North Zone. I think we're quiet because we went from having very little to support us with pediatric eating and swallowing to having this website and all these tools. So I think it's going to take us a little bit of time to, for it all to sink in. I just love, the types of things that you guys included. I love the look of it. I've always loved the name PEAS. I just think that it's going to be so much easier to, to kind of sit down with local teams and do the planning. I'm really excited about the team charter. That's something that I really want to do at an even bigger scale now with the new pediatric service model, getting ready for September and October. So I think that some of these tools are going to be used, even bigger than PEAS, and then all the way down to the PEAS services, right? So yeah, so thanks for everybody's hard work.
Yeah, thanks, Dalik. Thanks for your reflections and sharing and highlighting some of the tools that you think would be a good place to start. So I see, Lorianne, you've added some comments, and Teresa, thanks kindly. Any other thoughts anybody wants to share? Yeah, and if nothing comes to mind immediately, that's okay. Again, you can use the email address or the page on the website, and we can stay in touch that way. Oh, I heard a mic.
I just wanted to say, Tricia, too, that one of the things that really struck me is just how much of our pediatric model of care is really so apparent in all of this work, and I think it's a really great example of what we can do and how foundational those core aspects of the model are in the work that we're doing going forward. So I just really congratulate everybody for their work on all of this. So thank you.
Yeah, and you know that intimately because you've chaired that work. And yeah, I just want to, when you look at everybody on the line today, everybody's been involved at some part of the journey, right? Whether it's tools and resources under health profession strategy and practice, vision, mission, strategies of the organization, and like Melanie highlighted earlier, Vanessa has just been such a key resource for us to move this work forward in a project manner. So really, I don't know, it's such a team effort. It's been a great experience. Okay, well, I think our time is wrapping up. So if there's no other discussion or comments, I think we'll wrap it up. And again, really appreciate all the comments in the commentary. Wishing you all a wonderful summer day, and yeah, we'll be in touch with the future sessions. So take care, everybody.